Good afternoon and good morning, everybody. Thanks for joining us and welcome to this third in a series of webinars on using the MediSense Nociception Index Monitor to help dose analgesic medications. I am Frank Overdijk. I'm an anesthesiology professor and consultant medical director to MediSense. I'm based here in Charleston, South Carolina. The first webinar was on successful strategies on implementing nociception monitoring. Sort of the how and the why of nociception monitoring. In the second webinar, we had two clinicians specializing in bariatric surgery and the care of obese and morbidly obese patients. They told us how to use this monitor and allow them to personalize anesthesia, to minimize or avoid opioids, and to achieve excellent outcomes. In this third webinar, we are going to focus on how to use the monitor during cases with regional anesthesia. Regional anesthesia nerve blocks are the cornerstone of ERAS and multimodal analgesia. Regional anesthesia is now a best practice, and it's an integral part of us optimizing our anesthesia outcomes, decreasing discharge times, decreasing post-operative nausea and vomiting, PACU discharge, those kind of things. All of us anesthesia clinicians are curious when a new technology is introduced. We try it, sometimes we like it, sometimes we don't appreciate the benefits. We are delighted to have with us today two clinicians who were curious about a new technology. They tried it, and they became convinced that this monitor allowed them to evaluate the efficacy of their regional anesthesia blocks in real time and respond to inadequate analgesia in a way specific to that patient at that time during the surgery. So what we call personalized anesthesia. They had objective feedback to the nociceptive element of their care. They are going to share their pearls of wisdom with us today on how to achieve better outcomes when using regional anesthesia and using this monitor to measure nociception. So Dr. Marco Rispoli is a cardiothoracic anesthesiologist at Minaldi Hospital in Naples, Italy. He does mostly thoracic anesthesia cases and is a member of the thoracic subcommittee of the European Society of CT Anesthesiology, as well as a member of the European Society of Regional Anesthesia. And he's been using the NOL for a little over a year. Marco, welcome. Dr. Esteban Salas Rezola is an anesthesiologist at the Hospital General Universitario, Dr. Balmis, in Alicante, Spain. He will share his experience with NOL in upper limb surgeries, where he places upper extremity blocks and other analgesic strategies using the NOL index. Let me start with a short introduction for those of you who are new to the concept of nociception monitoring and the device. If you've seen the two prior webinars, you have heard this introduction already, so you can go get a cup of coffee and come back in 5 minutes when our experts start sharing their interesting experience with NOL during regional anesthesia. Next slide, please, Joel. So as anesthesia providers, we are responsible to provide these three components of an anesthetic. Since the 1970s, we've had an objective monitor of muscle relaxation, the Train of 4 monitor, which has been vastly improved now to give us the quantitative monitoring of neuromuscular blockade. In the 1990s, we got our first objective monitor of depth of anesthesia, the BIS, and we've had several technologies that help us measure depth of anesthesia, the SedLine, Narcotrend, etc. But we've never really had an objective monitor for guiding dosing of analgesics intraoperatively. And those are typically opioids. We rely on surrogate vital signs, heart rate, blood pressure, but these are not necessarily indicative of pain or nociception in patients. There are many other reasons why the heart rate and the blood pressure fluctuate during surgery. Next slide, please. So pain is defined as a subjective sensation, can only be given to us by the patient. The patient can only tell us what their pain level is. But under anesthesia, the patient is unconscious, so they can't tell us. So the appropriate term for pain is nociception. And nociception during surgery is manifest by the activation of the sympathetic nervous system. Our blood pressure and our heart rate increase, our pupils dilate, our skin starts to sweat, etc. So currently, we anesthesia providers tend to look primarily at blood pressure and heart rate as surrogates for nociception and to guide our administration of analgesics. The NOL uses a finger probe to sense changes in the blood vessels, the heart, and the skin to quantify the amount of nociception, as seen here in the 3 white boxes. Next slide, please. So here is the transducer. It's a sensor that sits in a cradle attached to the finger. The sensor uses light to measure the plethysmograph, or the photoplethysmograph, which we are familiar with because it's the same signal from which we derive oxygen saturation. This probe does not measure oxygen saturation. It only uses a single light wave frequency as opposed to 2 with the PPG. To measure the pleth amplitude, it measures the heart rate and the skin conductance, and to quantify nociception. So it uses these input metrics, their variability, and their derivatives in a machine learning algorithm to calculate the NOL index. The probe also measures temperature and senses movement, but uses these only to establish operational limits for the monitor, not as part of the NOL index determination. Next slide, please, Joelle. So the NOL index scale, as you can see on the right here, goes from 0, no nociception, to 100, which is extreme nociception, with any NOL value greater than 25 sustained for at least a minute, implying that the nociception anti-nociception balance is inadequate for the stimulus, and that the provider should consider giving more analgesia. It is not a linear scale, which means that the NOL index of 50 does not imply it's twice the nociception as a NOL index of 25. It's simply an ordinal scale, which means that the higher number is likely to be a greater stimulus than the lower number. And as with any continuous monitor, recognizing patterns and trends offers the most important and useful clinical information. Where is it coming from? Where is it going? And what does that pattern look like? I'm not going to get into the specifics of the algorithm here, because we need to spend as much time as possible with our experts discussing the clinical aspects of NOL during regional anesthesia. And there are online resources where you can find that information. Next slide, please. Oh, that's the previous slide. We'll go forward on that one. There we go. Okay, so great, folks. We're going to have everybody, if you have any questions, please use the Q&A box on Zoom. Some of these may be answered. The technical questions will be answered by our Medisense staff, but others we will discuss at the end of this, in these discussion, these cases that we're going to present now. Next slide, please. Marco, welcome. You used the NOL monitor during thoracic anesthesia. And in this first VATS case, you placed a block. Please describe and tell us, give us your pearls of wisdom.
Thank you for the possibility to talk in this webinar, and good afternoon to everybody. I will report my experience in nociception monitoring and how this technology changed my habits in operating room, that I think is the main relevant part of implementing a new monitor in our clinical routine. I work mostly in the thoracic surgery operating room, and this is our protocol for the lobectomy. We perform a TIVA TCI general anesthesia, and for the analgesia, we rely on a continuous paravertebral block infusion. We position the catheter at D5, usually, with ultrasound guidance, and we perform the bolus of ropivacaine to have a good spread of the local anesthetic. That is one of the most controversial part of this block. And then we keep on a continuous infusion, just like an epidural, a thoracic epidural analgesia. When we talk about the spread, we took the habits to monitor the proper drug infusion and the metameric diffusion of the paravertebral block using methylene blue. This colorant, this dye, is totally non-toxic and is useful in thoracic surgery because the surgeon could spot it through the parietal pleura, and you have a direct feedback on your block. Obviously, this is not possible in all the operating room or not in all surgery in which maybe the pleura should be inspected directly. So it's not a possibility that can be used for every patient. Apart from the paravertebral block infusion, we administer a multimodal endovenous analgesia with ketorolac, clonidine, dexamethasone, and paracetamol. Next, please. So when we started to use the NOL monitoring, we try to compare the methylene blue feedback and the pattern of NOL monitoring during surgery. Try to understand how this could affect our opioid consumption and how it could be the substitution for the methylene blue spread. For example, in this case, we have a 76-year-old man with the lung adenocarcinoma undergoing a left lower lobectomy, video-assisted left lower lobectomy. Is a strong smoker, COPD, obviously, hypertension, and for the one more into thoracic anesthesia, he has not good functional respiratory test, preoperative functional respiratory test. So we started our TIVA TCI, and we had the perfect catheter, paravertebral catheter positioning, as you can see with the methylene blue at the D5 space with the metameric rostrocaudal spread. In fact, during surgery, the consumption of opioids was at one of the lowest for the case. No need for rescue when we awake the patient. And we have a good NRS after surgery for the first 40 minutes, then the patient was moved. So I just talk about the immediate postoperative time. You can see in the NOL pattern, the orange dot line are the incision and the diathermy of the first trocar penetration into the thorax. You can see it's just a transient rise that is going to lower. The second peak is the second trocar surgeon insert into. Then we have another interesting fact. There is a gap between the red line. I like this case because this is a reality case. The sensor was moved because after performing the second access, surgeon asked us to reposition the side position of the patient. So moving the hand, the sensor was moved from the finger. We have to repositioning it to calibrate again the monitor and start again, just like with any monitoring. And this is an important fact. You have to work in a dynamic way with your monitor. It's not just a magic number. You have to work to make it function properly, just like the pulse oximeter or the ACG during surgery. If we stop to work, you just don't wait. You have to do something to recover the data. So, as you can see in the pie chart, most of the surgery was totally under pain control. And this is a good result considering the small amount of opioid used. Next, please. In this other case, we have a female patient with some similar story, better respiratory condition, but we had totally different anesthesia protocol. In fact, as you can see in the right lower corner, the methylene blue is not represented at all. There is just a bit shape of blue, but maybe something more intercostal. So we can consider it a failure of technique, which is quite strange because I performed the technique. And this is another interesting part, the bias of over and under confidence in our local regional analgesia technique. I was totally sure that my catheter was in the proper place because the patient was slim, the ultrasound window was very good. I don't know, but the catheter should have moved during the needle retraction, for example, or during the fixation of the drape, but something didn't work. And I understand it with the methylene blue, but I could understand it using the NOL. As you can see, even without specific description, this is totally another story. This monitor is telling a totally different history. we have a frequent peak over 25 cutoff. So the patient was not covered in a constant and satisfactory way. I had to rise the remifentanil during surgery at a certain point that I prefer to start even ketamine continuous infusion because personally I don't prefer to rely only on one opioid when I'm performing a total intravenous anesthesia and when I have a failure of regional analgesia technique, just like in this case. The difference is that I understand that my technique was not properly working just after 30 minutes from the start of surgery. So I had all the time to prepare the plan B and to make my patient awake in a more comfortable way because I was just prepared for the ketamine infusion, for the bolus of morphine rescue. So I could manage to control a non-sufficient intraoperative regional analgesia technique. But my overconfidence bias could bring me to keep on the path of regional analgesia, failing my target of assure the patient a good pain control. Next, please. And you can see in a dramatic way the difference between this technique. So using the methylene blue, it's easy, but if you could imagine to cover the left side of this monitor and just watching to the pie chart of the NOL monitoring, we still not have a magic number because there are a lot of variation. Maybe in a single center with same surgeon and same anesthesiologist, we could even find the magic cutoff number in NOL or opioid consumption that can determine if our regional analgesia technique is working. But for now, you can see directly the effect and to understand that most of the time we have to run after the pain in the lower part of the screen. In the upper part, we didn't run at all.
That was great, Marco. It was really very interesting. The over or under confidence in our ability in our blocks, and blood pressure and heart rate may not have shown what the fact that it was failing, correct?
Yes, I didn't report hemodynamic pattern because I concentrate, since I'm using NOL, I'm no more reporting the hemodynamic pattern because I didn't watch at them in the same way. It's a different part of my anesthesia management. I realized that this just after creating the slide, and I had the same idea. But why I didn't report the hemodynamic? Because I don't rely for the nociception on the hemodynamic. So I don't consider it relevant for my analgesia management.
You don't trust it. You don't trust it to be specific enough.
Not at all.
Right. Perfect. Dr. Esteban, Salas, Rezola, welcome as well. And we look forward to hearing your case reports.
Okay, awesome, Marco. Thanks, Frank, and good afternoon, everyone. So I bring you some cases of peripheral limb blocks and fascial abdominal blocks. Dr. Rispoli has told us something about thoracic surgery, so I bring you some abdominal surgery. So next slide. So this is the first case. It's an interscalenic nerve block in a humeral tumor resection. He was a very young boy. This was one of my first cases when I realized that I could trust the NOL index. So sometimes in my hospital, at least, when surgeons push a little bit to start very quickly, I don't know if you happen the same in your hospitals, but so you perform a general anesthesia if you don't trust too much in your block. So we place an LMA with propofol. And so as you can see at the beginning, this is the starting time. This high NOL index is the placement of the LMA. So I perform the interscalenic block. And the next NOL rises, it's because we have the incision of the skin. So sometimes the skin is not covered by your block. It doesn't mean that your block is not working. So you can see that traces a little bit, you can think, okay, is it the skin? Because as you can see, after that, the NOL remained very, very, very low the rest of the surgery. So I really trust. I thought, okay, my block is working. I don't need more opioids. So I didn't use more opioids, nor more fentanyl, nothing else, till the patient awaked. This is again the staples, and we close sevoflurane and the extubation, where the remove of the LMA. Okay, so in this case, we can say, for me, it was really important to have a guide of my nociception stimuli, because I could trust in my block when my patient is asleep. So you have here on your right side the whole procedure that I had. I had 86%, I guess, of NOL, 91% of NOL under 25. So next slide, please. So this is a major abdominal eventration, was massive, huge abdominal eventration in a 57-year-old patient. He was just hypertense and he took bisoprolol. So I performed a quadratus lumbarum block. Is some very similar to the classical tap block, but a little bit. If you go to a posterior size, the three abdominal muscles come joined into a fascia. So you put the local anesthetic there. And yeah, next slide. So this was the beginning when I performed the quadratus lumbarum block with ropivacaine 0.375, 20 milliliters. So we can see the NOL stays at below 25. Next slide, please. We got a hypertension event with 1790 with high NOL. So I add a little bit of fentanyl. You have to understand this is a very interesting thing, because you have a somatic block. It's a block of the abdominal wall. It's not a visceral block. And I realized that they were touching the bowel. So I add a little bit more fentanyl, and the NOL came down under 25 again. So next slide, please. And you see that we have another hypertension event, but with the really, really low NOL index, okay? And this is very interesting, because you have 60 beats per minute of the heart rate. So if you remember, this man took bisoprolol. So if you can want to guide your analgesic approach just with the heart rate, you are not going to be able with that, because this patient took beta blockers, okay? So next slide. So I didn't use more analgesic, nor more opioids, just some vasodilators. Okay, in Spain we have urapidil, but it's the same of clevedipine or whatever vasodilators that you have in your hospital. I treated hemodynamic events with hemodynamic drugs. In my classical approach, before this monitor, I used to put some fentanyl or whatever with a hypertension event, okay? But the NOL told me that it was not a nociception event, it was just a hypertension event. So next slide, please. The NOL remained very low. Next slide, please. And this is another quadratus lumbarum case, but in this case was a laparoscopic surgery in a bilateral adrenalectomy. And so at the beginning, you have here the picture of the quadratus lumbarum block. So you can see the external obliquous muscle, the internal one, and the transversus. So when they joined in the fascia, you put the local anesthetic. So the QL1 is the lateral approach, because there are another two approaches of this kind of fascial block. So we start the surgery. So I perform the quadratus lumbarum with ropivacaine again. And here you have the collocation. So we must put the patient in a lateral position for the adrenalectomy. You can see the NOL rises, but it's because you have an endotracheal tube. You have to remember always that the patient could have some nociception stimulus, but not because the surgery, and it's because the movements, okay? Just wait a little bit that it's going to come down again, okay? So next slide. As you see, the NOL stays really, really low, and at some point it rises. It was the incision, okay? So I add some fentanyl, 100 micrograms, comes down again. And I got here, sorry, I didn't add the blood pressure here, but I had an hypotension event. So I add some ephedrine. So look at this. If you add some vasopressors to your patient, the NOL index is going to rise always. But because it's a AI, it learns from the patient and it's going to come down again to the baseline. Okay, so you have to wait a little bit, 1 minute or a couple of minutes till the NOL index comes down again, but again rise up. So I didn't trust in my blog in this point, so I add some remifentanil and 0.2, okay? So the NOL came down again. Next slide, please. And remain really, really low. And at this point, I stopped remifentanil because I realized that I was overdosing my patient, because if the NOL stays below 10, it tells you that you are overdosing your patient. So I stopped remifentanil at this point. And next slide. So this is very interesting moment. You have an hypertension event of 70, 80, but with a really, really low NOL index, almost 0. But what happened here in a classical approach, I will again added some fentanyl or remifentanil, whatever. But what happened in this point is that the surgeons were touching the adrenal. So we got a catecholaminergic event. It's nothing about nociception stimuli. So what I did is treat the hemodynamic event with, again, some vasodilators. Next slide. So this is your turn, I guess, Marco.
Yes, thank you, Esteban. Okay, this is another interesting case because I talked about my overconfidence bias in the previous case, in which I was sure my catheter was in the right place. This is the opposite case, in which the NOL changed my routinary practice. This is a radical mastectomy in a patient with a high cultural gap. She had some psychiatric problems. We could not talk with her, even with the cultural mediator, trying a different language. She was very scared and stressed about surgery. So our surgeon tell us that they could not exclude the necessity to get into the thorax due to a suspect of pleural infiltration, even of some ribs. So we prepared the patient for a thoracotomy because we could not be sure what would be the surgical conduct in this case. Positioning the thoracic epidural catheter in this patient, it was up to me, was really difficult for the resistance and the fear that the patient had during the procedure. The loss of resistance was not very pronounced. That is typical for the thoracic district, but in this case was even worse due to the low patient compliance despite sedation. Once I finished my procedure, even with the smooth catheter progression, I was not safe at all of performing a proper technique, but I lost a lot of time. My surgeon were waiting for me. The patient was so stressed that I decided to not perform another attempt and to use a total intravenous anesthesia, relying on high dose of opioid to control the intraoperative pain. Then happened something strange. Next, please. Because as you can see from the NOL, I had to intubate the patient with the double lumen. And I'm not afraid to admit that having lost a lot of time, I was in a hurry. Surgeon was pressing and stressing me, so I have to perform quite a fast intubation, and I didn't have the time to prepare a proper analgesic plane. So I decided to try a epidural bolus, the fastest thing I could do while preparing the patient inside position and draping the surgical field. And as you can see, even if my bolus arrived at the target just together with the first surgical incision, the NOL trace is going to lowering in a quite fast way, keeping it totally under the 25 cutoff, even lower. That is typical of a continuous regional neuroaxial analgesia. And while I was preparing high dosage of remifentanil analgesia with ketamine, with anything I could rely on, even magnesium and lidocaine, I understand that my locoregional analgesia technique I was not relying on with an underconfidence bias was the best way to keep the intraoperative pain control for that patient. And as you can see, even in the most cruent part of the surgeon, I didn't have rise in the NOL pattern. The use of remifentanil was low, very low. It's just for my safety. We were joking about this. Than for the patient. We use the usual multimodal endovenous analgesia, but this is the common part of our patient. But this case, for me, I'm very related to this case because it was one of my way of changing this monitoring. I would have not used the epidural catheter for this surgery. I changed my mind using another monitor that allowed me to see something that is totally under the level of the sea if you are not looking for it. So this is an example of an underconfidence bias. Next.
Thank you, Marco. It changes me again as you, my approach, this monitor. So I will make the same as you. So I bring you this case, my last case, to answer the question about can we use the NOL index in a patient without muscular relaxants? So it's a 25-year-old female patient with no medical history. The induction was with propofol, fentanyl, and rocuronium. And because it's a thyroidectomy, we have the neurophysiology monitoring, so we cannot use relaxants, okay? So after the induction, we have a reversal rocuronium with sugammadex, 400 milligrams for this neurophysiology monitoring. And I used total intravenous anesthesia with a perfusion of propofol and remifentanil. So at the beginning, so next slide, please. At the beginning, next, we can see the remifentanil, please. So I start after the reversal with a little bit high doses of remifentanil, 0.3. You have to maintain a little bit high the remifentanil for the beginning. They're just going to make the incision. There's too much movement, and you are going to make a reversal of the rocuronium. But next, please. This is the reversal of sugammadex. We can see the NOL index stays really, really low. And next. So I decided to put a little bit down my remifentanil because the NOL stayed really low. Next. And this is very interesting moment. You have these two spikes of the NOL index. And what happened here? So I just watched the surgery and next. So it was a head movement, okay? It's a movement of the endotracheal tube. So, but you don't have to add more analgesia, just wait a little bit because it's going to come down again, real down. So next, what happened is that I stopped my remifentanil because I realized I was going to overdose my patient. And at the end, this is the stop time. I tell you this because this is a very short surgery. So in short surgeries, and after the surgery is not very painful because you only had this incision, okay? So it's very easy if we don't have a good monitoring of our an analgesia approach, you are going to overdose very easily with opioids, okay? You have a very intense stimuli during the surgery, and you're going to use probably much more remifentanil or fentanyl than without monitoring. Okay, so and to answer the question, yes, you can use it without relaxants. Okay, and if the patient is not moving, and even it's moving, remember that you have a sensor of accelerometer. So if it moves a little bit, the hand, the monitor is going to correct it and remove it. Okay, next, please.
Okay, so
This is
it's up to
yours.
me, Esteban.
Yeah.
Okay, this is another thing that changed my practice. I have to be honest, it still didn't change my practice because I don't know how I could change this practice, but I'm sure something has to be made in a different way. And now I'm going to explain. Because this is a procedure of a percutaneous dilatational tracheostomy. We are not talking about an emergency procedure. These are elective tracheostomy we perform in patients with neuropathy, sclerosis, or muscular dystrophia. We have a specialized center in our hospital, and the clinician prefer to have tracheostomy with the percutaneous dilatational technique. So they asked us to perform the technique instead of the surgeons. We perform the procedure in ICU, but they are not patient properly from ICU. It's just a logistic problem because we don't have an operating room to perform this kind of surgery. So this is not ICU application, but it's something relevant because when we perform a lot of techniques in sedation, we rely on the local anesthesia. And we used to demand to the surgeon to perform the local anesthesia. But how does this really impact on the nociception of our patient? We are used to tell to the patient to be patient, sorry for the jokes, to tolerate, to stay calm, to do not over express the sensation, but maybe he's feeling pain. And we are not thinking about it because we are in overconfidence bias. I have administered lidocaine, so patient cannot feel pain at all. This is not true. And as you can see in this case, I performed the technique in a patient with a very easy anthropometric pattern. She was very slim. She had an acute on chronic respiratory failure requiring a continuous positive pressure ventilation in spontaneous breathing. She needed for several bronchoscopy to perform secretion removal, and she had an amyotrophic lateral sclerosis and a history of acute coronary syndrome. So we preferred to not use at all opioids and just to perform a deep sedation with the propofol bolus and positioning LMA and IGL-1 to have an airway control during the procedure. As you can see, the first peak in the NOL, but it's really a transient one, is the positioning of the laryngeal mask. So during the bronchoscopic inspection, the draping, the positioning, the preparation of the sterile field of the neck, I performed my local anesthesia with the subcutaneous lidocaine 50 milligrams. That is more or less 3 milliliter of my 20 milligrams per milliliter of lidocaine. Obviously, patient didn't feel any kind of pain, but what happened when I start the technique on the red arrow? You can see the NOL immediately start to rise. And even if the overall procedure is very fast, I'm not so good, the patient was very easy, she felt pain. So we stopped during the insertion of the last dilatational horn to administer a fentanyl to have a better pain control, but we could not manage. And so for all the procedure, if the patient was sleeping, sorry for the simplification, she was feeling a nociception during the procedure. After the positioning of the tracheal cannula, the NOL monitor was stable. There was no nociception. But this patient is going to be awake just after the procedure, because our hope is that she's going to come back to spontaneous breathing as soon as possible. Now, we don't know how this pain, the stab in the neck, the fear of this sensation could impact on a weaning. We don't know, and it's not up to this discussion. But the thing that made me change my practice is that my local infusion for chest drainage, tracheal access probably are not enough. And this is another way the NOL changed my mind.
Excellent, Marco. Thank you. Wow, what a great smorgasbord of cases, all sorts of different cases. And really, in summary, I think we can say that the NOL index allows the provider to verify the effectiveness of their regional block, regardless of your confidence or lack of confidence. You gave very nice examples of both sides of that. And sometimes we do start an infusion or give a bolus to treat us, not so much the patient, but we use our historical, our experience saying, well, we should be doing this. But it's a very nice objective monitor to use. I'd like to ask you a few questions. The audience had some great questions too. We'll get to those in a second. Each of you in turn, starting with Marco, how long did it take before you to get this confidence that you have now in the monitor? How many cases did you have to do? What was the variety of cases? And then Esteban after.
Okay, thank you for the question. We have been using the NOL for about 6 months. So now I cannot tell the exact number of the case, but I can tell something relevant. It if doesn't challenge you, it won't change you. The first case with the NOL was not so easy to understand for me. I have to be honest, because you need to be trained on this technology. You have to pass through a cultural gap. You have to understand the difference in pain and nociception. And you have to be convinced that you have to monitor the nociception. This is the first cultural step, that it's not involving the NOL, but it's necessary and mandatory to make your machine work. Because if you are not totally into the relevance of this data, you are not going to spend the time needed to understand how this monitor works. Then you have to understand some little trick. I had a great support from the specialist of the medicines, because as any kind of sensor, you need to reach the perfect interface on the finger of your patient, different sides, patient in different position. So if I have to tell you a magic number, I imagine that after the first 10 cases, I was totally more confident in the NOL data, and I understand how to solve some of problem with tip and tricks that you are going to learn in a practical use. Esteban, this is my opinion. I'd like to ask you for the same.
Perfect. I cannot say nothing else, Marco. Yeah, right. Well, I've been using, thank you, Frank, for your question. I've been using this monitor since I think 7 years ago. I started using it with the first version, the 0.0 version. And I have to say that Medicines have made a really, really great work developing this device, because the one we have now is much, much better in order to have a more stable signal. And so I recommend to the audience that if you want to start using it, I recommend to use it, yes or yes. Because I believe that, and it changed, as Marco said, it has changed my approach to the analgesic strategies. So we need to monitoring. You monitor the hypnosis, you monitor relaxants. Why not monitoring nociception? So you need to, you must do it. But I recommend you, if you want to start using it, start with very, very simple cases. The one I bring you of the TIVA in thyroid, just cases with total intravenous anesthesia with remifentanil. It's very easy. You're going to see how you rise a little bit the remifentanil, the NOL index comes down, and the other side. So start with this. Don't take any clinical decisions. Just observe it. And in a couple of months, in a few months, you're going to be able to take some clinical decisions to add some epidural, whatever. But at the beginning, okay, just be patient. So just remove the sensor, if it doesn't work, the same as you make with other devices, just be patient. The signal is going to come in a couple of minutes, okay? So, and see what happened. But use it. It's non-invasive. It's very easy. It's just a sticker. So put it on, watch it, and then in a couple of, you ask about the time, Frank. So maybe in a couple of months, okay, you're going to see that it works. But you have to you need to know these little tricks and some tips. Just that.
Those are great answers from both of you. They're honest answers. This is not something that on day one is going to be transformational for you. It took me a number of cases, and then I had an aha moment, as we call it. I went, aha, wow,
Yeah.
now I get it. And it will come to you. Some people a little faster than others. There's a good question. In this webinar, we focused on regional anesthesia. You guys have given us great examples of how the NOL helps you interpret the effectiveness of your block. But in previous webinars, we talked a lot about interpreting the contribution of hypnosis, the depth of anesthesia, the depth of hypnosis, the depth of anesthesia as well. How important is it for you in cases with general anesthesia to use a depth of anesthesia monitor as we talked about the triad, muscular blockade, nociception, and hypnosis? How do you guys do that in your cases with or without regional anesthesia?
I try to answer. I found the two parameters totally linked together. It's impossible to differentiate the proper approach to anesthesia without considering both of them. In fact, you can see that the deep of sedation could have some relevance on the nociception, and even a high nociception coverage rate of opioid administration could impact of your consciousness. I think that the tailored anesthesia we all talk about is to get the best result we can achieve with the lower dose of drug we need. So best way to use the monitor, this kind of monitor, is in a synergistic way. In my clinical practice, I even reduced the use of hypnotic drug and opioid drug while I'm using in the same time NOL monitoring and deep depth of anesthesia monitoring. And this is one of the most relevant facts when I started to use this kind of technology. Just like for the depth of anesthesia monitoring, we thought it was about awareness. Then we understand that it's about to tailor the proper drug to the proper patient. Maybe for the NOL is happening something more similar. We are not doing more or less opioid. We are giving the right dose of opioid. That is something totally different. So yes, if you want to magnify, to have the greatest result you can achieve, we have used the monitoring in a synergistic way. This is definitely the best way.
Completely agree, Marco. And of course, you have to use it combined. It's perfect to use it everything together because it opens your mind. Just you get the aha moment. I understand now everything. When I combine everything together, it got poof. And I remember the last webinar, one of my colleagues talked a little bit about how she combined the DCA, the density spectral array, and the relation with the NOL changes. And it happens. We have some changes in the brain waves with nociception stimuli. So you can check, you have a double check. You have the NOL check and you have the DCA check. And when you combine together, it's absolutely perfect. So yes, you have to do it combined. And yes, you use less hypnotic, you use less opioids, but it happens the same. When I remember when I was a trainee, I started making anesthesia. We don't have any hypnotic devices in my hospital. So my professors didn't use intravenous anesthesia. They use inhalatory anesthesia, okay? And when we start monitoring hypnosis, we start making more intravenous anesthesia. We was safer for the patient. So this is the same. We are going to make a safer surgery, and we are going to improve the patient outcomes if we have a really good monitorization of the nociception. Less hypnotics, less opioids, not less, just the one the patient needs that Marco has said. What the patient, the individualized, because it's very individual. We have a very different responses in each patient.
Yeah, and it's about that personalized anesthesia that we're talking about.
Thank you, Frank. I didn't find the word.
Yeah, no, it really is, and we're no longer going around in the dark using just experience and milligrams per kilogram dosing, which is really archaic, right?
That's it.
Why we're very much smarter. So I'm get the sense from both of you, and both of you endorsed monitoring the triad, monitoring everything. So fair to say you would not go back without practicing without this monitor? That would be going back to a square wheel, or it would be right. You would not do that. We have a couple more quick questions that I want to answer. You've both mentioned, you both explained very well spikes in the NOL that were attributed to not necessarily nociception, to movement, to pressors. You both reiterated that you have to understand how the monitor works. This is not a black box. You have to understand what the inputs are, and then have to understand how the machine learning algorithm personalizes that. And somebody asked a question about false positives. So certainly movement, Trendelenburg can give you a quote unquote false positive. I'm not sure it's truly a false positive in that sense of the word. It is the physiologic response to the Trendelenburg, to the movements, to the increase in heart rate from an ephedrine that causes that so-called abnormality. But you have to understand that. Just a couple of quick questions for individual things, and then we'll summarize for the cases. If I can get to the ones here. Somebody asked about were you surprised in the failed block for the lobectomy, Marco, that the NOL was only above 23% of the time?
Yes, I was surprised, but this costed me a huge rise in remifentanil infusion. I reached 4 nanograms per milliliter. That for me is a huge amount of remifentanil. I can't remember now the total remifentanil use, but it was a relevant dosage. And you have to consider that I started to infuse ketamine. So I had ketamine, remifentanil in high dosage, multimodal analgesia with other drugs. So I'm happy the NOL, yes, the answer is I'm very happy. It was over 25 for less than a quart of the surgery, but it costed me a lot of drug. When I talk about cost, I mean hemodynamic risk for high opioid rate infusion, a high risk of hyperalgesia using remifentanil, and a dependence of opioid in the postoperative pain that could not make my patient adhere to ERAS protocol or any kind of early mobilization that in thoracic surgery is a must. But if you consider that I would not, if I would have not the NOL by my side, I would not understand my failure of technique because I was totally felt in love with my regional analgesia technique. And I made my patient suffer for all over the surgery. So the best part, even if I failed my technique, I had a plan B that allowed me to get only 23% of undercover nociception. This is the great deal. I understand the thing even before the problem was up to me. Okay.
Yeah, yeah. Last question, and if you can answer in a minute or so, it's a relevant question these days of clinical evidence for why should the administrators in your hospital spend the money on a monitor? How will it improve? What sort of outcomes, tangible outcomes, you suspect it may improve down the road? We've talked about really tailoring anesthesia to the patients, and we've seen the benefits, hemodynamic stability. We've shown a lot less PACU pain. But what are those outcomes that you think in longitudinal research will show this monitor to be beneficial? Esteban, you want to start off that one?
Well, I think to resume a little bit and not be very long, the point is that what the papers say is that with this kind of monitoring, we use less opioids. So that's true. And so we have less secondary effects of these opioids, what leads in a less hospital stay, less stay in critical units, in after anesthesia recovery rooms. So that means less spend of money, because maybe the 1 day in a PACU, it's in Spain is maybe, I don't know, 1,000 euros, and you are spending just one sticker. So yeah, it's to monitoring these patients, so it's going to lead in a less spend of money in the hospital.
If I could add something, just in a short way, I know that I'm creating a huge mass effect at the end of the webinar, but this is the reality. It's difficult to understand how a pain control approach can change some outcomes, just like complication, length of stay, and mortality. Even for more tangible and for more commonly used technique, it's impossible to estimate the proper impact on this strong outcome. So I don't think it could be demonstrated, but as Frank previously said, it's up to a tailored anesthesia, is to give our patient a more sophisticated product.
Yeah, and I think that's totally the right answer. And we're not. You guys are really pioneers in this, and 50 years from now, people are going to look at these webinars and are going to say, why did we not do that? Like monitoring of pulse oximetry, or like the depth of anesthesia monitoring. So in that sense, it's been extremely useful, I think. We have a lot of questions. There are a few technical questions that we'll have the panelists answer to you individually offline. But I think we've come to the full hour. This has been fabulous. And Dr. Marco Rispoli, Dr. Esteban Salas Rezola, you guys are really resources that are tremendously rare, of course, this early in the adoption of the technology, and your experience is fantastic to share with you. So I'd like to thank you both for your time, your interests, and taking the best care of our patients. So with that, we are going to close up, and thanks to everybody, and good evening, good afternoon, and on to the next patient.